Assalamu alaikum. My name is Dr. Idris. Today I'm going to present uh, the renal mass and its clinical presentation and evaluation. Today we will learn about the epidemiology of the renal mass and risk factors, its clinical presentation and investigation, and to understand about the paraneoplastic syndrome and staging of RCC and renal mass biopsy. First of all is epidemiology. RCC account for 2 to 3% of adult malignancy, and male to female ratio is more is 1.9 to 1%. North America has greater incidence, followed by Western Europe and Australia and New Zealand. Belarus is a nation with high incidence in the world, 16.8 per 100,000. In US, about 74,000 new cases of RCC reported in 2019, accounting for 4.2% of all cancer diagnosis. The incidence is first reported in 1975 is 7.5 per 100,000, and in 2016 this incidence is rise up to 14.9 per 100,000. The steady rise has made the kidney cancer one of the fast growing kidney cancer in the US. Risk factor of renal cell carcinoma are non-modifiable and modifiable. Non-modifiable are age, sex, and race, and modifiable are smoking, hypertension, alcohol, drugs, occupational exposure, and obesity. First is non-modifiable. Age is the most commonly RCC is diagnosed between the age 55 and 75 year of age, and RCC is uh, uh, develop in about 50% of the patient with VHL disease, and it diagnosed in early age between third to fifth decade of life, and usually bilateral and multifocal. Sex, it is more common in men, and male to female ratio is already described that 1.9 to 1%, and they have low survival rate. Race, African American and Hispanic American and Native American has greater risk of RCC than white Americans. And papillary subtype is common in African American, while the clear cell carcinoma is common in Caucasian American.
इसमें आपने पीछे कहीं आगे कहीं वो VHL का बताया हुआ है?
VHL
आगे है कोई स्लाइड में?
no sir, VHL.
Anybody VHL? Dr. Yumna VHL. डॉक्टर फाद VHL. तो एज उन्होंने एज एक तो एज से रिलेट आप कर रहे हो, 5 to 7 बिटवीन 7 डिकेड आ रहा है लाइफ है. इधर ये VHL से इसकी कोरिलेशन बता रहे हैं, 3rd to 5th बिटवीन द 5th डिकेड आ रहा है लाइफ. क्यों और क्या है ये VHL?
VHL one reduced syndrome associated mostly with the tuberous sclerosis, and mostly 60% of the patient of the tuberous sclerosis develop RCC, mostly clear cell, and patient has a
tuberous sclerosis. You sure? Because ये जी आप बताएं मरियम.
It is also dominant syndrome, and it is characterized by three different phenomena. One side renal and pancreatic cells, and third one is iris cell and medullary. And it is again hereditary in nature, so it involves bilateral kidney, and also multifocal in nature,
and tend to be aggressive.
Tend to be aggressive. And also characterized by the absence of tumor suppressor genes, and I guess chromosome number 3.
Good.
Next is modifiable risk factor of RCC. Smoking, it contains carcinogen, which are polycyclic aromatic hydrocarbon, beta, naphthalamine, and nicotine. These are filtered through the kidney nephrons and metabolize and promote inflammation and induce DNA damage, and thus promote carcinogenesis. And second is obesity. The precise pathogenesis of obesity remain unclear. It promotes resistance to insulin and insulin-like growth factor, facilitate uncontrolled tumor growth, release of inflammatory cytokine, and disrupt metabolic homeostasis, and such as stimulating the release of adiponectin and leading to overproduction of DNA damage-free radical, lead to carcinogenesis. Next is diet and alcohol. The correlation between the diet and RCCs seem to be not as strong as neoplasm in gastric and colorectal cancer, and heavy in meat-based protein, fat, and dietary products are associated with high risk of RCC, and heavy drinking is associated with increased risk in both men and women. Hypertension. Hypertension damage the renal glomerulus and tubulus apparatus and associated with increased risk of RCC. Poorly controlled hypertension and time since the diagnosis of hypertension both significantly increase the risk of developing RCC. Occupational exposure. RCC is not classified as occupational neoplasm like bladder and mesothelioma. Most is trichloroethylene, a solvent used in decreasing agent and degreasing agent and spraying fixative for art and public drinking water has associated with increased risk of RCC. Other are asbestos, benzene, vinyl chloride, herbicide, and cadmium. Next is drug. Overdose of acetaminophen and NSAIDs and painkiller are associated with increased risk of RCC. They induce the DNA damage which is required for proper functioning of kidney. Now proceed is clinical presentation of RCC. Mostly RCC are diagnosed on incidental finding on abdominal imaging like ultrasound, and benign renal tumor are ever increasing and commonly in urology clinic because of widespread use of abdominal images. Over half of the renal tumor may have no symptom and more likely confined to kidney. Classic triad of the symptom. The classic triad of symptom is not really seen because of increasing use of non-invasive imaging ultrasound, thus detecting disease at earlier stage, and it is curable. The classic triad include flank pain, hematuria, palpable abdominal mass, and if the classic triad is present, then it denote that the disease is diagnosed at late stage and it detect poor prognosis, and therefore referred to as too late triad. Patient may present with advanced disease include constitutional symptoms such as weight loss, fever, night sweat, and malaise. And some rare presentation is spontaneous perirenal hemorrhage. Underlying mass may be obscured. Mostly an RCC and AML is present, which is diagnosed on repeat CT after few months.
अच्छा, ये spontaneous
Next. And if metastasis of disease, then the patient present with bone pain and persistent cough and with hemoptysis and paraneoplastic syndromes seen in metastasis disease, which we'll describe later on. Other important physical finding is cervical lymphadenopathy is due to showing advanced disease, and the inferior vena cava is involved, and then it lead to bilateral lower limb edema. Varicocele, if present on the right side, it depicts the RCC, and on non-reducible left side varicocele point toward renal mass, which has involved the renal vein. Approximately 30% of the patient with RCC present with metastatic disease. The physical examination should include thorough evaluation for metastatic disease, particularly in following organ: lungs 75%, 36% in soft tissue, 20% in bone, liver 18%, cutaneous 8%, and central nervous system 8%. Now the investigation, first lab investigations, it include urea creatinine, in which we see serum creatinine and GFR, glomerular filtration rate, and complete blood count, see the HP, ESR, erythrocyte sedimentation rate, whether it is increased or not. Liver function test to see the bilirubin, ALP, AST, and serum calcium if there is hypercalcemia or not. Urinal analysis and ALP if is raised in bony mets, and split renal function using renal scintigraphy is usually done in when there is solitary kidney or tumor is present in bilateral kidney. Other tests are indicated by the patient clinical picture, for example, paraneoplastic syndrome workup. Imaging modalities include a number of imaging modality are usually evaluated in stage the suspected renal carcinoma. First, we do ultrasound, then the gold standard is contrast enhanced CT, chest, abdomen, and pelvis for staging. MRI is done when there is contrast allergy. Renal arteriography now rarely used. Venography, MRA, bone scan if bony mets is suspected or ALP is raised, and brain CT or MRI if the patient has clinical manifestation suggesting brain mets. This is a axial image of the CT abdomen contrast enhanced, which shows renals, which shows heterogeneous mass involving the right kidney, well circumscribed, and show enhancement on arterial phase, and that depict renal cell carcinoma. Now, paraneoplastic syndromes associated with RCC. It is very important to evaluate for paraneoplastic phenomena because they can be a source of major morbidity and can affect the clinical decision making. And it is found in 10 to 20% of patients with RCC. It is usually non-metastatic systemic effect, and elevated ESR are found in 50% of individuals. In paraneoplastic syndrome, usually associated with increased calcium hypercalcemia is due to overproduction of 125 dihydrocholecalciferol, and it has clinical presentation are nausea, fatigue, anorexia, and decreased tendon reflex, and is treated by bisphosphonate therapy, is now considered standard care, and more definite treatment is include nephrectomy and occasional metastatectomy depending upon the clinical circumstances. And medical management also include vigorous hydration followed by diuresis with furosemide. Hypertension is usually hypertension is due to increased production of renin or compression of the renal artery by the tumor, which lead to hypertension. Polycythemia. Polycythemia is due to overproduction of erythropoietin, usually in response to hypoxia induced by tumor growth, which is directly by the tumor. Now, Stauffer syndrome. Stauffer syndrome is usually referred to non-metastatic hepatic dysfunction, and in which there is elevated ALP and prothrombin time, serum bilirubin and transaminase are elevated, and other is hypoalbuminemia. Symptoms include fever and weight loss in Stauffer syndrome, and hepatic mets must always be excluded. Biopsy, when indicated, is usually represent necrosis in Stauffer syndrome, and nephrectomy usually lead to resolution of hepatic dysfunction. If the symptoms still occur after nephrectomy or metastatectomy, then it detect poor prognosis. Other less common but distinct paraneoplastic syndrome associated with RCC are Cushing syndrome, galactorrhea, hyperglycemia, clotting disorder, and cerebral ataxia. In general, the paraneoplastic syndrome is usually cured by surgical excision or systemic anti-neoplastic therapy. In hypercalcemia, except in hypercalcemia, medical therapy has not proved helpful. Next is staging workup. The TNM staging is now used. It has replaced the Robson system. Tumor stage is based on the size and extension of cancer into renal vein and extrarenal structure. Pathological stage is very important prognostic factor for RCC. T is the size of the tumor, and N is spread to the nearby tissue, N is spread to nearby lymph node, and M is metastasis. And T is further divided into T1, T2, T3, and T4. T0 is no evidence of tumor, and T1 is defined as tumor less than 7 centimeter and limited to kidney. It is further divided into two types, T1A and T1B. T1A is less than 4 centimeter, and T1B is more than 4 centimeter but less than or equal to 7 centimeter. T2 is defined as tumor is limited to kidney but more than 7 centimeter. It is further divided into T2A and T2B. T2A is tumor greater than 7 centimeter but less than 10 centimeter. And T2B is more than 10 centimeter but confined to kidney. T3B is when tumor extend into major vein and perinephric tissue but not beyond the gerota fascia or not into the ipsilateral adrenal gland. It is further divided into three types, T3A, T3B, and T3C. T3A is when tumor involve the renal vein in its branches and pelvic calyceal system or perirenal or renal sinus fat or but not beyond gerota fascia. And T3B is tumor involve the inferior vena cava below the diaphragm. And T3C if it involve the vena cava above the diaphragm. And T4 is if tumor invade the gerota fascia, it or include the extension in the ipsilateral adrenal gland, it is T4. And N is a lymph node mets. N0 is no regional lymph node, and N1 is metastasis in regional lymph node. And further is stage 1 is T1, and there is no nodal involvement, no mets. Stage 2 is T2, no nodal involvement, no mets. Stage 3 is T3, no nodal involvement, no mets. Any T1, T2, and T3, and if the lymph node involved, it is included in stage 3. And T4, stage 4 is T4, any N, and any no mets. If metastasis is present, then any T include in stage 4. Next is renal mass biopsy. Percutaneous image guided biopsy of renal mass is safe and accurate procedure and previously only reserved for diagnosis of unresectable renal cell carcinoma, metastasis, lymphoma, and infection. There is increased awareness that a substantial proportion of small solid renal mass are benign neoplasm. Although the imaging can be used to diagnose most of them, some are incorrectly believed to represent RCC and unnecessary surgery may be performed. Based largely on advanced cytological technique, percutaneous biopsy can now be used to diagnose benign neoplasm, thus prevent them from being treated unnecessary. According to European Association of Urology 2022 guideline, renal mass biopsy should be done in following cases: to obtain a histology of radiologically indeterminate renal masses, to select the patient with small renal mass for active surveillance, to obtain histology before or simultaneously with ablative treatment, to select the most suitable form of medical and surgical strategy in setting of metastatic disease. Renal mass biopsy is not indicated for comorbid and frail patients who can be considered only for conservative management. The procedure of renal mass biopsy is shown on this video.
Tissue sampling of the renal lesion is performed under image guidance, commonly CT or ultrasound guidance. It is often performed on outpatient basis. The patient lies on the procedure table. The initial CT images are obtained. The location of the lesion in the kidney is determined. The biopsy device cannula entry site is marked on the skin. Then, the access site is sterilized. The access area is covered by a surgical drape. The skin and renal capsule are numbed with a local anesthetic at the access site. A very small nick may be made in your skin to make it easier to pass the needle into the renal lesion. Then, the tip of a cannula is placed within the renal lesion under CT guidance. The biopsy device is prepared and then advanced through the biopsy cannula into the lesion. Subsequently, multiple passes are performed to obtain required tissue samples. The entire procedure usually takes between 30 to 60 minutes. At the end of the procedure, the biopsy cannula is removed and pressure is applied to stop any bleeding. Subsequently, dressing is applied at the opening on the skin.
The procedure is done in our setting is mostly ultrasound guided, and at the end of procedure, pressure dressing is applied, and patient is allowed to bed rest for 6 to 8 hours. And the procedure can be performed as outpatient at hospital, mostly done ultrasound guided or CT guided as described in this video. A percutaneous route is most common mode of biopsy, and biopsy needle is passed through skin to remove the tissue from the renal mass under radiological guidance. Technical detail and complication. When performing a renal mass biopsy, consideration should be given to several technical factors that may affect the diagnostic and complication rate. The guidance modality depict the lesion and adjacent structure, and needle tip should be used to guide the biopsy. Each modality has its advantages and disadvantages. Ultrasound provide a real-time imaging without ionizing radiation, but may not visualize the lesion. CT is more expensive and however will allow depiction of the mass and surrounding structure. MRI is seldom used but may not help to biopsy the mass that is not seen by ultrasound or CT. Operator preference and equipment availability also play a part in decision which imaging modality is chosen. Diagnostic effectiveness of renal mass biopsy. The purpose of percutaneous biopsy is used to obtain a tissue diagnosis safely. The biopsy result should have implication on the patient management. Therefore, obtaining a benign diagnosis is as important as malignant one. The absence of malignant cell from biopsy, however, does not necessarily confirm the benignity and should be viewed with caution. Sensitivity and specificity for renal mass biopsy range from 80 to 90% and 83 to 100% respectively. False negative results are likely due to inaccurate needle placement or obtaining necrotic tissue. False positive results are rare and are likely much less frequent today due to advanced cytology. Complication of renal mass biopsy are mostly hematoma, which is 4.9%, usually resolved. Gross hematuria 1%, 0.4% hemorrhage required transfusion, and 1.2% clinically significant pain, and pneumothorax 0.6%, and pseudoaneurysm. Overall, however, a renal mass biopsy is a safe procedure. Most hemorrhage are subclinical, that is self-limited, and can successfully manage conservatively. Thank you.